Good evening. We would like to welcome everyone to the Adrenal Disease Awareness Month webinar hosted by the American Association of Endocrine Surgeons and in partnership with the National Adrenal Diseases Foundation. I'm Dr. Susana Vargas Pinto at Nubens Health, an endocrine surgeon in Connecticut, and I'm one of tonight's moderators.
Hi, good evening. We're so excited to be here. I'm Dr. Lilah Morris-Wiseman, and I'm the other moderator for the webinar tonight. We have assembled an expert panel. Some people are still trying to get into the meeting, so we will hopefully have two more joining us. And we really want to answer some common questions about adrenal disorders. We've taken the questions from the NADF membership, and tonight's webinar is being recorded and will be made available on the AAES Facebook page and YouTube channel. We want to thank the NADF for really helping us with this and hosting us. We'll be taking live questions from the audience. And so you can answer your questions into the chat. We can't provide any specific medical information. And we'll start by introducing our expert panel. And so, Dr. Graham, do you want to introduce yourself?
Sure thing. Thank you. I'm Paul Graham. I'm an endocrine surgeon at MD Anderson Cancer Center. I'm pleased to be here. Thank you for the invite.
Dr. Smith.
I'm Philip Smith. I'm an endocrine surgeon at the University of Virginia in Charlottesville, Virginia, and I'm grateful to be part of this group.
Wonderful. And we're hopeful to have our endocrinologist, Dr. Amir Hamrahian, who's from Johns Hopkins, and then hopefully also Dr. Carmen Solórzano, endocrine surgeon from Vanderbilt. So we'll just get started.
Dr. Graham, could you give us a brief overview of some of the reasons why patients might need to have adrenal surgery?
Yeah, thank you. Yeah, it's a common question. A common reason why we're seeing patients is for an adrenal mass or an adrenal incidentaloma. So the patient may come to us with diagnostic imaging that shows an adrenal mass, or may have had an evaluation by a medical provider or an endocrinologist that show concern for hormonal dysregulation, and so come to us to decide whether the adrenal glands are culprits and whether they need any surgical intervention. As we know, the adrenal glands have multiple layers and produce multiple different hormones from those layers. So you can have an adrenal tumor that produces too much hormone and may need to be removed for that reason. And then you can also have adrenal tumors that can be malignant, either a primary malignancy of the adrenal gland or a malignancy from somewhere else to the adrenal gland that may render them also needing to come out. Occasionally, we'll get imaging from an adrenal, from a CT scan or an MRI that may show an adrenal gland suspicious for something, but not fully diagnostic of a cancer or anything. And then it's a process of deciding whether that adrenal gland needs to be removed or not. So we have both kind of a hormonal evaluation that we do and kind of a structural or imaging evaluation that we do. And those give us a good idea of kind of a surgical need.
That's great. One of the questions submitted was about the successive surgeries, sort of what percentage of adrenal operations are successful. So I want to break this down into a couple parts. And Dr. Smith, I wonder if you could tell us a little bit about kind of how you think about the operation itself as being successful. You know, what are the different types of adrenal operations, and sort of what things do you think about with minimally invasive approaches versus open approaches to make the operation a technical success?
Sure. I think big picture, regardless of the approach, if you're thinking about a successful operation, then there's a few things that jump fairly immediately to mind. One is, of course, that if there's the reason you're operating is some excess hormone secretion, that you actually achieve success in resolving that excessive hormone secretion. Another, of course, is that if your reason for operation is either concern for cancer or knowing that someone has a cancer, that you achieve the adequate operation to give the patient the best chance of a long-term cure of that. Adrenal cancer is fortunately rare, but to have a chance of curing it requires a technically successful operation. And in that case, that means taking the tumor out completely and intact without rupturing it and without leaving anything behind. Depending on the reason you're operating, fortunately, we now have multiple options for how to go about the technical performance of that operation. Decades ago, the only option or the main option was it was a large incision, and we didn't really have minimally invasive operations. And adrenal surgery is an operation I think has really particularly benefited from the option of having minimally invasive surgery because I think we know it has really changed the impact on the patient and their recovery. Fortunately, the majority of adrenal surgery can be approached with a minimally invasive approach, and we now have options for that. There's what's called the transperitoneal approach. So this is a laparoscopic operation, small incisions, typically spaced under the ribs or other places on the abdomen, and using instruments to work without having to make as big of an incision as you would without this laparoscopic approach. And we can do a similar approach, what's called the retroperitoneal approach, where instead of coming basically from the front, we come from the back. So this involves typically 3 small incisions spaced under the ribs on the side of the adrenal in question. There have been some studies looking at whether one approach is better than the other, and there's at least a suggestion that with the retroperitoneal approach, there might be less pain and a faster recovery. But when we've looked at the aggregate of this data, probably is not that one approach is the right answer for adrenal surgery. It's a combination of what the surgeon is comfortable doing. I use both approaches, as I'm sure others do, and the decision is based on what the lesion looks like, the patient's history, any prior surgical history. If someone's had a lot of operations in their abdomen for other reasons, that would be a compelling reason to want to approach it from the retroperitoneal or posterior approach. But as long as the surgeon is comfortable in the approach and they choose one that's appropriate for the patient and the problem that's being treated, then that's more important than one approach over the other.
Dr. Morris-Wiseman, some patients undergo adrenalectomy to remove tumors that secrete too much cortisol. Can you talk about success of this procedure?
Sure. I think people always want to know, sort of how successful this is going to be. We can think about adrenalectomy being recommended when the adrenal gland secretes too much steroid or cortisol, and that causes a variety of problems, things like weight gain, particularly in the abdomen, thinning skin, proximal muscle weakness, like difficulty standing up from a chair, easy bruising, bone loss, frequent infections. And this is called hypercortisolism or Cushing's syndrome. And so taking out an adrenal tumor that is producing too much cortisol is very successful and really can be life-changing and cause resolution of all of the symptoms that were being caused by the tumor. There's another group of patients with less excess cortisol, but still a major disease problem called mild autonomous cortisol secretion. And those people have an adrenal tumor that is in and of itself not producing too much cortisol, but doesn't turn off effectively when there's more cortisol in the body. And this can also cause a variety of maybe more subtle problems like high blood pressure, bone loss, diabetes, weight gain. And what we know about patients with this mild autonomous cortisol secretion from a randomized trial where patients with this were assigned either to surgery or to kind of best medical control of their other problems, that the patients who had adrenalectomy did better. They saw improvement in all of these areas, whereas the people who were just treated for their diabetes or hypertension, they got worse. And so we can't always attribute all of the health problems to these adrenal tumors, but when we do this functional workup and they show that the adrenal tumor is secreting too much cortisol, then taking that out can be very successful. Let me ask you a question, Dr. Vargas. I wanted to ask you about success for another adrenal problem, primary aldosteronism. Do you think you could tell us a little bit about what that is and the success when that's treated with surgery?
Yes, of course. So when we have a problem of increased aldosterone production, a lot of times this can come from one of the adrenal glands, or sometimes it can come from both adrenal glands. Sometimes there are patients who have a tumor or a nodule, and that's the one that is overproducing the hormone. It's coming from only one side. When that is the case, surgery has proven to be very successful in helping these patients. We can expect that about 37% of the patients will be off the blood pressure medications with adrenalectomy when it's a unilateral problem. However, as the patients are older and they are on multiple medications, as it is often the case, we often see that a lot of times there's a benefit in terms of reducing the amount of medications, but some patients may not be able to come off completely from the blood pressure medication. But up to 80% of the patients who undergo adrenalectomy can actually have a benefit in reducing the amount of medication that they need, and they experience better quality of life. When the aldosterone production comes from both glands, we usually prefer for that to be treated medically. And surgery is a little bit less helpful in that sense. A lot of the times, the patients that are younger usually present with unilateral disease, and they tend to respond better to surgery. And patients who are diagnosed later on, they usually present with bilateral disease. In any case, every endocrine surgeon considers that it's very important to consider selecting the patients for surgery. And part of the workup that we do, at least in my practice, it includes adrenal venous sampling, essentially because we want to make sure that the disease is confined to one gland, and those patients have been shown to do better with surgery.
That's great. I want to turn to one other type of tumor, and then the audience questions are excellent, so we'll bring in some of those as well. I wonder, Dr. Graham, could you tell us about adrenalectomy for pheochromocytoma? What is pheochromocytoma? What type of surgery do you do for this? And then if you could also talk a little bit about different types of surgery specifically for pheochromocytoma.
Yeah, absolutely. Thank you. So when we're talking about the different layers of the adrenal gland and the different hormones that they secrete, the innermost layer is the medulla, or if you're Queen's English or regular English, and that area can grow tumors. And if they grow a tumor, they can produce too much of the hormone from that layer, and that's an adrenaline hormone. And that adrenaline hormone can give you adrenaline rushes, where you have high blood pressure, palpitations, high heart rate, things that you would get in kind of a fight or flight response. And over time, that high blood pressure can cause multiple comorbidities where you can have increasing high blood pressure to the point of maybe stroke, heart attacks, things of that nature. So they're a very active tumor. with dire consequences and should be removed. They also have a potential to have to be able to spread to other parts of the body where they're not supposed to be. So what we would call metastatic disease. And so for a malignant potential or metastatic potential, they should also be removed too. In most cases, when they're contained and there's no major risk factors to them, which that's still kind of being worked in the study of these tumors, whether a large size or certain genetic mutations or certain predispositions might make something more of risk of cancer or malignant potential. But most of them can probably be resected through one of these minimally invasive approaches that Dr. Smith discussed. Occasionally, they can be large enough or invasive enough or even show metastatic potential to where it's maybe better handled through an open operation with a larger incision and better visualization for a large tumor like that. One of the questions from the webinar chat was, what are the criteria for cortisol-sparing procedures? And that's where that comes into play a lot with our pheochromocytoma type tumors, because the outer layer is what produces the cortisol. The inner layer is, again, the adrenaline type hormones. So if we have an ability to separate some of that inner layer from the outer layer, we can hopefully sometimes keep a patient's cortisol function in more normal range. And in pheochromocytomas, there's a very heavy genetic predisposition for it, and that many of these tumors are a result of a hereditary genetic mutation. And that also predisposes patients to multiple tumors or bilateral tumors. And if you have bilateral tumors and possibly the need for bilateral adrenalectomy, it's good to try to preserve some cortical tissue or some of that outer tissue so that maybe someone can be steroid-free in the future.
That's great. Thank you. And thanks for answering that question on the chat. I think Dr. Hamrahian may be on speakerphone. So are you here?
I can hear you, Lilah. Can you hear me?
Wonderful. Yes. Do you mind introducing yourself for us?
Yes, sure. This is Amir Hamrahian. I'm an associate professor of medicine at Johns Hopkins University. I'm the medical director of the Adrenal Center, and I have the privilege of working with Dr. Morris-Wiseman as part of the Comprehensive Adrenal Center.
Wonderful. Thank you so much. And I'm so glad that you're able to join us. We have a couple questions for you. If I can ask you, we talked a little bit about surgery for patients with hypercortisolism, but could you talk about some of the medical treatments for hypercortisolism and when patients would go on medical treatment versus surgery?
Sure, happy to. First of all, I would like to start with this notion that in most cases, I prefer the surgical option over the medical treatment. The reason is that the medical treatment going to be for most patients lifelong and going to be, and usually is expensive, and there needs to be very close monitoring with the treatment option that we have. But there are situations that we use medical therapy, and one of those situations in patient with a bilateral adrenal tumor or hyperplasia for hypercortisolism. Even in those cases, sometimes we go after one adrenal gland and then reevaluate the patient and then decide about the medical therapy. Usually, we do not take both adrenal glands out unless there is a severe hypercortisolism. So the treatment options include estrogenesis inhibitor, the glucocorticoid receptor antagonist. We have medication mitotin in a specific that can be adrenolytic, that can help. We usually using the patient with adrenocortical carcinoma, and can help with the cortisol management, hypercortisol management. And there are some other new drugs that are being tested. For example, the drug that can inhibit the conversion of the cortisol to cortisol, which is an active hormone. And the estrogenesis inhibitors, there are a number of them available in the market, and we use them based on the patient characteristic, the level of the hypercortisolism, and the comorbidity of the patients.
Great.
Excellent.
Thank you so much.
Dr. Hamrahian, now that we have you on the line, can you talk to us also about medical therapy for primary aldosteronism when patients are not eligible for surgery or when the aldosterone levels get very high from aldosterone overproduction from the contralateral side?
Sure. So there are two main medications that we have as a mineralocorticoid receptor antagonist that we use for medical therapy. And one is spironolactone, and the other one is eplerenone. And the spironolactone is a more potent drug. However, we prefer to use it in women. In men, because of the androgen blocking of characteristics, it can cause breast tenderness and lump in the breast. So usually we use eplerenone in men for medical therapy. There are some other drugs being tested, such as aldosterone synthase inhibitors that are in the clinical trials and seem to be very promising, and hopefully will add to our arsenal for treatment of a patient with primary aldosteronism who are not eligible or have bilateral disease or could not be cured by the surgery.
Great. Let's go back. Dr. Smith, can you discuss why someone may need more than one operation? There was a question that came up, how predictable is this? What is sort of, as we talk about kind of success and failure, when do you think about reoperation, or when do you ever see this?
Sure. It does depend certainly on the reason for the original adrenal operation. And this does dovetail somewhat to what Dr. Graham was talking about in terms of particularly patients with genetic syndromes that are lead to a increased potential of having bilateral or both sides pheochromocytoma. So when he talked about cortical sparing adrenalectomy, where we're trying to avoid people needing to be on steroids, there's a few studies out there, but the numbers I keep in my head, in part because they're easier to remember, is that approximately 1 in 10 patients who've undergone cortical sparing adrenalectomy over a period of about 10 years will end up having a recurrence of pheochromocytoma, either in the remaining portion of the adrenal gland or less frequently in basically the area where a allegedly completely removed adrenal gland has some potential remnant. So there, of course, are other reasons. So some patients who have nodules on both sides may have undergone adrenalectomy on one side, say for hyperaldosteronism, but then the nodule on the other side will continue to be monitored. And it's possible that that remaining side could cause an additional problem of excessive hormone secretion, or if the imaging characteristics, again, as Dr. Graham discussed, are concerning for cancer in that adrenal gland, that could be another reason to return. We talked a little bit about adrenal cortical carcinoma, the cancer that arises directly in the adrenal gland. Again, fortunately, quite rare. But when it does happen, it certainly can recur. And in some cases of recurrence, reoperation is appropriate. In some cases, reoperation isn't the right answer. And that's a complex decision-making process that involves careful review of scans and discussions amongst the multidisciplinary team taking care of the patient and with the patient as well, of course. And then a small group of patients may end up having surgery on both adrenal glands due to cancers that started somewhere else and spread to the adrenal glands, lung cancer, various other cancers. This is something we're starting to see some of as the treatments for those other cancers have gotten better. Occasionally, that's the right thing to do, but not the main focus of what we're talking about today.
Okay, great. Thank you. Dr. Hamrahian, I have seen a couple of questions in the chat from patients who are suffering from adrenal
I'm
insufficiency.
gonna turn off my phone.
Okay.
Sorry for that.
Welcome.
So finally, it looks like it's working now. Yes, please.
Yes, we have a couple of questions in the chat from patients who are suffering from adrenal insufficiency. And a lot of the questions basically want to know what other options do they have other than the hydrocortisone replacement, if anything else.
Okay, so I mean, there are other type of glucocorticoid that the patient can use. One of them, for example, is prednisone. And sometimes in situations like congenital adrenal hyperplasia, we may use a long-acting medication such as dexamethasone when there is a need to have a better control of the patient hyperandrogenism and ACTH level. But the reason we use hydrocortisone in most patients is because we try to simulate the normal cortisol rhythm, the diurnal variation. So that's why it's easier with the hydrocortisone to do that. So we usually divide the dose to 2 or 3 times. Some patients feel better on 3 times daily, and some patients would like to have the convenience of taking it only twice daily. So that's why we give the biggest dose in the morning, maybe smaller dose about noon, and the smallest dose about 5-6 p.m. So that is the main approach for the patient. I mean, there are other treatments also available, like using a pump, for example, hydrocortisone pump. There have been some studies in the literature, but these are for special cases, for example, mostly as a part of a clinical trials. So it's not something that we use on a day-to-day practice that we use. There are some other also option maybe down the road, like a transplant options for some patients, for example, who especially don't have autoimmune disease, that does the body will not attack the adrenal cells. But so hopefully there are situations that we can use other options. But for now, the main option would be using a type of a glucocorticoid plus minus the mineralocorticoid replacement fludrocortisone that we use for most patients with a primary adrenal insufficiency. If they have secondary, they would not need that.
Yeah.
Dr. Graham, let me ask you one of the questions from the chat. So a patient has and obviously we're not talking about this specific patient, but how would you manage patients who have bilateral tumors? And we can even talk about bilateral cortisol producing versus bilateral adrenal nodules and co-secretion of aldosterone and cortisol. How do you, giving you some complex questions, but this is from the chat. So how do you think about those situations?
Yeah, so complex situations, agree. So typically when we see bilateral adrenal tumors, we're kind of going through that same initial workup of a functional workup and an imaging workup. And in many of the situations you described, we're kind of more leaning towards benign type of disease. And so then we're going through the functional algorithm. And with the functional algorithm, we really want to kind of prove that someone has excess hormone, either in the cortisol, like you're saying, or the aldosterone scenarios, to prove that someone's actually having problems, medical problems as a result of too much cortisol or aldosterone. And I think both of those are appropriate because we have kind of a second line of confirmatory tests that we do often in testing those diseases, because we want to make sure that someone really is in excess of those hormones and affected by it. At that point, if we kind of decide that someone has excess hormones, then there may be a scenario where we can determine whether that is coming more from one side versus another side, and then may therefore benefit from removal of the dominant side. And if not, then it's kind of a discussion of whether a patient may kind of be, we'll say, debulked a little bit in their hormone excess by removal of a gland. And in rare cases, if they're suffering severely of both glands, that's a very complex situation, because as we kind of see a lot in the webinar chat, people suffering from low cortisol function, that's the flip side. We don't want to take more adrenal tissue that we do and have to render someone adrenal insufficient. So sometimes it seems like it's a long process to kind of prove that hormonal excess evaluation, long process to try to prove whether it's a unilateral or bilateral source. But I think those are all steps that people that deal with this a lot like to go through, because we kind of know the end ramifications if we go too far and need to take both adrenal glands.
I wonder if we could ask Dr. Hamrahian to talk a little bit about clinical trials. Who is a good patient for a clinical trial? What should they be thinking about?
Yeah, so, and we are referring to patient with hypercortisolism, is that right?
Yes, I think that's the main area that we want to ask about.
Yeah. Well, I mean, one of the things for being part of a clinical trial probably is that the patient should have to be able to commit to the time frame of the clinical trial and coming for the visit according to the protocol. If the clinical trial involves a placebo arm, which sometimes they do, especially when the company is trying to get an FDA indication, it probably would not be a very good option for patients with severe hypercortisolism, because some of the patients may need to receive placebo arm. We had a gradient study that has been finished, and they're going to be announcement in a different society presentation as an abstract, and then the paper will come out about the use of relacorilant, it's the glucocorticoid receptor antagonist, without anti-progesterone effect, so it doesn't cause endometrial hyperplasia, and without causing the elevation of the ACTH, which can lead to hypokalemia in some patients. So that study has been finished, and some patient has been moved to an extension part of the study. The study did not meet the primary endpoint for the blood pressure, but it did improve the patient glycemic control, blood glucose control in different parameters. There was a GRACE study, same medication using for patient with more severe hypercortisolism, using the relacorilant. That the study also has been finished, and we're waiting for some of the presentation about this study. There is ongoing studies about the drug that inhibits the conversion of the cortisone, which is inactive form to the cortisol, which is the active hormone, with the 11-beta-HSD type 1. So the medication blocks that, so it decreases the active hormone, the cortisol. That's ongoing studies. Right now, we do not have any open studies for patients who want to participate in a hypercortisolism study, but we expect that there's a significant interest in hypercortisolism, especially the fact that the prevalence can be very high, and you can do the math, 5% of the population and about 20% of these patients can have hypercortisolism with an adrenal nodule or hyperplasia. I hope I answered the question. I hope I didn't.
That's perfect. Yeah, there's a lot of questions about.
But I'll be happy to have a more specific about any specific thing. I'll be happy to give you more information.
Dr. Vargas, did you want to ask one of the questions from the chat, or I can as well?
Yes. My connection broke a little bit, so I don't know if Dr. Hamrahian mentioned this or not, so I apologize. But one of the questions in the chat was if there are any available clinical trials for patients with Addison's disease, or if there are any reports of successful transplantation of adrenal glands for this patient population.
We do not have any open studies for patients with Addison disease. As you know, most of the audience know that most of the patients with Addison disease, they have an autoimmune disease. So that becomes problematic with the transplant, because that would be a big hurdle for that. I mean, that would be mostly helpful in patients who have a non-autoimmune primary adrenal insufficiency. So unfortunately, right now, we do not have any open study for Addison disease. There is an interest in quality of life in these patients, looking at that with the different regimens and try to see how does it affect the quality of life, but well-being and the fatigue. So some of these are ongoing in some of the centers, as well, but we do not have an active study right now.
Thank you. I wanted to ask Dr. Graham. So one of the questions, if someone is diagnosed with a functional tumor and is planning to have surgery, how do you decide to remove the whole gland or just the tumor? I know you had talked a little bit about cortical sparing adrenalectomy for pheochromocytoma, but there's certainly been a lot of interest, a lot of talk about partial adrenalectomy for other tumor types. So wondering your thoughts about that.
Yeah. And this will be mostly in the context of, or should be in the context of benign adrenal tumors, in which we're considering leaving behind some adrenal tissue. Often seen in diseases where we know we can leave a little bit behind, maybe a risk of recurrence of disease, but not necessarily concern for malignant disease recurring. I think a lot of the evaluation depends on the location of the tumor formation within the gland, and whether it's feasibly able or technically able to be spared. So our adrenal gland has three kind of different limbs. It's like a three-legged starfish. And sometimes a tumor will grow off one of those limbs, leaving the other part of the adrenal gland intact or normal appearing. And so the ability to kind of separate normal adrenal from tumor portion is a little bit more applicable in those situations. Whereas some grow from the middle and spread through the whole gland. Kind of analogy I use a lot with patients, it's like a deflated long skinny balloon, and you blow the balloon up and maybe have a little bit of the deflated balloon portion left. That's the normal part, and we're trying to take the inflated balloon portion away. But sometimes it's a round balloon and the whole gland is affected, and there's not an ability to save normal tissue from abnormal tissue. So, and again, this is mostly in the context of pheochromocytomas. Other diseases like aldosteronomas or tumors that produce too much aldosterone can be a localized tumor as well. They're often small and often can be separated from normal adrenal tissue. And so those are ones that at times we consider doing a cortical sparing approach in it. The evaluation has to consider whether the adrenal hormone excess is actually coming from an isolated tumor and not from a hyperplasia or abnormality of the whole gland or from both glands, as leaving behind part of the gland will not really help solve the aldosterone excess. And then most tumors of cortisol producing are kind of involving the whole outer gland, and so it's hard to leave any gland in those situations.
I know that's been a hot topic of discussion from the adrenal community. What if, Dr. Smith, let me ask you, what do you think in your practice, sort of, do you see patients come in with adrenal tumors just found incidentally on imaging? What if somebody has a tumor that pops up on imaging for another reason? You know, do they need surgery? And who's the best person to see for that?
Sure. It's a fairly common scenario when we do CT scans for many, many reasons, be it lung cancer screening or people with belly pain. If scans include the adrenal glands, approximately 1 in 20 scans will have some sort of adrenal gland finding. And that's the term that I think has come up already, what we call an adrenal incidentaloma. It wasn't the point of the scan, but it was incidentally noted in obtaining the scan. Fortunately, the vast majority of those aren't functional and aren't cancer and don't need adrenal surgery. But what they do need is a thoughtful evaluation. And I think who's the best person to do that evaluation is quite variable depending on where you are. Certainly, the people on this panel all would be suitable to do so, but most commonly, that evaluation would be in the hands of either an endocrinologist or a surgeon, an endocrine surgeon, someone familiar with adrenal gland surgery. But depending on the physician, plenty of other primary care physicians are well suited for the initial evaluation at least. So if someone has an adrenal gland finding that is a centimeter or more, we recommend that there be an evaluation of that. And that, of course, includes a history of physical understanding the patient's medical background. Do they have hypertension on multiple medications? Do they have changes concerning for Cushing's? Do they have symptoms potentially of PHIO? But then there's a fairly standard biochemical testing that we would recommend in the majority of cases, including testing for all of those biochemical findings, all of those hormone excesses. And whether or not people need testing for all of them, and whether they need multiple tests or just one test, depends on the situation. For instance, the patient who has an adrenal mass and they have findings concerning for Cushing's, we're not going to just trust that it's not hypercortisolism based on a single test. So it depends on the clinical context, the degree of testing we'll go through. And then, of course, as I think Dr. Graham already brought up, the testing, the question of whether an adrenal gland incidentaloma represents a cancer is one that's based primarily on imaging findings. And as I guess I briefly mentioned, it's actually more common to have a cancer in the adrenal gland that spread from a different organ than it is to have adrenal gland cancer. So certainly the patient's history of other cancer would be highly relevant in that case. Unlike many masses that are found, nodules, things concerning for potentially cancer, this is an example where it is not the right answer to go straight to a biopsy of the adrenal gland. That is occasionally appropriate, but not in the initial evaluation of an adrenal mass. It can't reliably tell us if it's a functional adrenal mass, and it cannot reliably distinguish between a benign adrenal nodule and an adrenal cancer. And if it's an adrenal cancer, it is problematic to have ruptured the tumor, and that can impact the potential of cure at future surgery. So unlike many masses, adrenal biopsy should not be the first line. And if it is, in the small number of cases where it is appropriate, there should be testing for that pheochromocytoma because it's dangerous to biopsy those. I hope I answered the question. I think I meandered a bit.
That was perfect. There are a bunch of questions in the chat. We'll go back to Dr. Hamrahian about sort of the interface between pituitary and adrenal. Some questions about the impact of high ACTH, which is from the pituitary. And I wonder if you can talk a little bit about sort of pituitary excess of ACTH and how that might impact the adrenal glands.
Thank you, Lilah. So I'm looking at the chat box. So there are some questions about the fatigue in patients with adrenal insufficiency, and I get a good number of these patients in my practice. So one of the things we use is we try to, as a hydrocortisone equivalent dose for the patient adrenal insufficiency, we use about 8 to 10 milligram per square meter body surface. So by doing that, we try to kind of use not the same dose for everyone, but look at the patient, the height and the weight, and calculate the body surface area and adjust our medication. So sometimes I see that the patient just keep going up on their glucocorticoid dosage, thinking that would improve the adrenal insufficiency symptoms, and then you will end up with having too much cortisol on board, and both under treatment and over treatment definitely can be bad and causing a number of factors, including over treatment and causing myopathy and weight gain and a number of the comorbidities with that. So I think the patient should have, when patients are not feeling well and being treated with adrenal insufficiency, they should have a comprehensive exam done, evaluation done. Sometimes there are other conditions going on as a part of the autoimmune package, for example. They can have celiac disease, for example, the hypothyroidism. They can have a number of the rheumatological disorders. So these needs to be addressed, for example, the patient. One of the things that we see commonly in some of these particular population is that the dysautonomia, the POTS, can be very kind of mixed with adrenal insufficiency symptoms, and sometimes the patient needs to be evaluated, which is usually done through a tilt table study, and that can be helpful. There are special clinics that can help the patient. We call them usually POTS clinic, and sometimes they are hard to get in, but there's a long waiting list for them. So we do not use the ACTH as a good marker in this population. Sometimes we measure that and can give us some idea sometimes about the glucocorticoid absorption, for example. But it is not a very accurate measurement of the treatment success or changing the dose of the medication. I usually check it about 2 hours after the morning hydrocortisone dose, for example, to see where we stand. We look at the renin level to see the fludrocortisone treatment is adequate or not. We look at the potassium, blood pressure of the patient. So I think if someone look at all of these elements and have a comprehensive evaluation, that most patients should feel good or have a better quality of life while they are being treated for adrenal insufficiency going forward. That would be applicable to most patients. Now, again, I'll be happy to answer a question more specific way.
That's great. Thank you. I think we are getting almost out of time here. I just want to thank the panelists, our expert panelists, for being here. but also for the audience participation and the really amazing depth of questions. I know we couldn't get to all of them, but hopefully we covered some themes. I want to thank Kalina and our partnership with the National Adrenal Diseases Foundation. We were so excited to help celebrate the International Adrenal Awareness Day on April 7th, and really have enjoyed the collaboration. This webinar will be online hopefully in the next few days. If you are looking for an adrenal surgeon, the AAES webpage has a surgeon finder for high volume adrenal surgeons. We are just so excited to participate in this tonight, and I just I'm really grateful for our expert panel.
Thank you, Lilah. I just wanted to add one more thing is that in men, because men make testosterone, usually the adrenal androgens has less role, but in women, and the androgens can be important as a quality of life and well-being. So in some of these patients, when they are symptomatic, in addition to the classic treatment, we may offer them some like a DHEA supplement and then monitor their androgen levels, and some of the patient may feel better. So there are a number of the things can be done in these patients who may not feel well on the standard treatment.
Wonderful. Thank you so much.
Thank you, everyone.
Thank you. Take care.
Thank you again very much. I'll be in contact.